Our next speaker is coming for the second time. She's been on the hot seat before today. Joanna Flynn will bring us the aspect from the Medical Board of Australia and their current approach.
Thank you very much. And just as I start, I would really like to commend the College of Surgeons and Physicians in Australia and the Royal College in Canada for putting this meeting on and for the lively presentations and considerations today. There are a number of people from the Medical Board here listening avidly as we consider where we're going. So just a bit of a landscape and then some issues, but I want to start just with a story. So I said earlier today when I was talking about how I got into regulation that it started a long time ago, and I remember within about a month of starting on the Medical Board in Victoria in 1989 that we had a practitioner appear before us, and in those days a doctor who got to a certain point in the complaints process actually came and appeared in front of the whole board. And this was a general practitioner who worked in the eastern suburbs of Melbourne, and he'd been identified because he'd been writing certificates for a man saying he was unfit for work because he was suffering from asthma. And somehow his employer found out that he was actually working a second job, quite a physically demanding job during the same time, so he was getting sick pay from one place and employment in another. And when the doctor came in, he brought his little 5x8 card notes which showed that he was treating this patient's asthma with barbiturates. Now, I'm talking about 1989, and I know many of you in the room were in practice in 1989, and that was not contemporary practice at that stage. And when he was challenged, he didn't do any CPD, and he was very confident that his respiratory medicine skills were excellent because he'd worked at a tuberculosis hospital in Melbourne during the Second World War period and post that under one of the eminent chest physicians in Melbourne who had a knighthood. So that was all he needed to know. So I guess we don't get the situation anymore because 25 years down the track people do CPD and to some degree they're more connected. But the challenge here for us collectively today is CPD enough? If that man had been doing CPD, would he have actually been doing something that would have told him that barbiturates were not an appropriate treatment for asthma at that time? Okay, so currently we've got this scheme where the national law provides that the Medical Board and each of the other national boards under the national scheme set what are called registration standards, and two of those that are in the legislation say that we can set standards for continuing professional development and for recency of practice. Recency of practice essentially restricts people making changes of scope into new fields of practice without doing something before they do that. So you can narrow your scope, but if you want to widen or change, and it's a significant departure, you need to have a plan and the board's approval for that. And these standards that are developed have to be approved by the Council of Health Ministers. So to some degree we have to work within the political context of the time. Coming to the CPD registration standard, in 2010 when the board, or 29 leading into the introduction of the national scheme, when the board defined the standard, we set a framework which essentially said for people who were specialists in Australia on the specialist register, they would need to do what their colleges required. And for those who weren't, they needed to do some things that the board said. But we defined CPD fairly broadly, involving a number of activities to ensure expertise and competence and professional behaviour. And it's important again in this framework to recognise that the AMC is the accrediting body that accredits colleges and accredits as part of that the way in which they set frameworks for CPD. So, as well as the CPD, if I think and my colleagues on the Medical Board think about how are we as the regulator ensuring standards of medical practice in Australia, we have a number of declarations that people have to make when they renew their registration, that they're complying with the CPD requirements, they need to report any investigation or restriction of practice and any criminal history. We have a system of mandatory notifications if people are substantially below the standard or impaired. The system is based on annual renewal of registration, and from this year we're going to start a random audit of compliance with CPD and other registration standards. But this is in a wider context of lots of other clinical governance processes in Australia. So there are systems of accreditation of health services and of general practice, there are credentialing processes, there's performance appraisal processes which are very well developed in some places but less so in others, whole frameworks for risk management, audit, and we've heard some very interesting presentations about that today, all sorts of different ways of collecting performance data and quality assurance processes. But not all doctors in every context in Australia are included in those processes. So that's where we're up to. is this enough, or should we move towards a more formal system of revalidation? So the board announced at the end of 2012 that we were going to start talking about this. We had a forum to launch this conversation in March last year. And in fact, it is really exciting, as I said earlier, to see how much that conversation has taken off in Australia. And it's really about trying to give patients the assurance they seek that any doctor is competent and fit to practice, but being very mindful that whatever happens shouldn't undermine trust in the profession and shouldn't weaken people's intrinsic drive to professionalism. So I think the real challenge is, to what degree does or can college CPD programs ensure competence and professionalism? And would revalidation in Australia address problems or prevent problems in the competence or performance of individuals, in the trust and confidence that the community has in the profession, and the trust that they have in the regulatory standards and processes? And the question about what value it would add, what would it cost, and would the value justify the cost? And they're unanswered questions. So we've got to continue to work on these things, and they're part of the dialogue everywhere where these considerations are the subject of focus, about whether things should be diagnostic or developmental for everyone or for high-risk groups. Should we go for the wedding cake approach? And as I said, the medical board does not have a position on those things and really wants to engage with the profession about the what. And there are all sorts of tools that we've talked about earlier, and some of those, I think, look at different aspects. Some of them are more readily deliverable, and it's, as I said, important given the bi-national nature of Australian and New Zealand colleges and the fairly high level of similarity in Australian society, and a moderate level of comparability in our health systems that we work together. So I think it's really important that we very much keep patient safety as the focus. That's what it's about, and the quality of care. That we're looking at encouraging self-reflective practice and improvement of performance of everyone over time. And I think there is a level of wanting to make sure that everybody meets a minimum standard. But as we say that, it's really important to recognise that the practice of medicine is complex, contextual and diverse, and it's not easy to reduce it to measurable outcomes, and certainly not single outcomes that can be applied across the many contexts of practice. So we'll need to use a variety of tools. And as I said earlier, to take things that are there and sort of link them together rather than adding a whole lot of new stuff. And important about enhancing professionalism. When Richard asked me, Richard Doherty, about speaking, he was talking about feedback and what feedback does the board give or expect people to give. So at the moment, in fact, directly, the medical board doesn't give much feedback at all. It sets out standards and promotes them and publicises them. When somebody complains about a doctor, which is called a notification, then the doctor is informed. So currently about 4% of Australia's doctors are the subject of a notification per annum. As I said, we're about to start an audit process, so that will be some direct interaction with the board for a percentage of practitioners, and obviously if the response to the audit is not satisfactory, there will be further feedback provided. That will probably in the first place be, please comply, and then there will be further layers of feedback if that's not satisfactory. And of course we get lots of other feedback, formal and informal, from college and co-workers, from employers and from patients directly or indirectly, and through some of those CPD processes. And those of you who are in touch with the world of social media will realise that along with the other national boards in the scheme, we've recently ventured into trying to put out some guidelines about the use of social media and a new set of guidelines about advertising. But it's brought us into sharp focus that we really, the traditional way of looking at this doesn't allow us to deal very well with the sort of use of social media in rating sites. So the sort of TripAdvisor equivalents for medical practice or any professional practice, which are burgeoning, and where does that sit? Is that contrary to the advertising guidelines, and what would the board think about that? So in the law about advertising in the national law, it says that practitioners mustn't use testimonials. And of course, at some levels, you could say anything anyone puts up on a website saying, this was my experience of that doctor or that physiotherapist could be seen as a testimonial, but I think it's helped us to clarify that if the doctor didn't put it up and didn't instigate it, it's not actually advertising, it's not designed to promote. And of course, ultimately, I think it's the ultimate form of feedback, because there are some practitioners who never quite get the message about how they're coming across to their patients unless there's a way in which the patient provides that feedback directly. And when we go back up to the top bit about the notification, that's normally a point at which communication at the local level is broken down. People don't make a notification unless they feel that raising that with the doctor or the practice or their employer isn't going to work. So I think there is actually a place for that sort of social media in terms of providing feedback to people, but it has its problems, and as businesses who've had their hospitality industry place wrecked by crummy reviews, it certainly can be open to manipulation, so it needs to be looked at carefully, but still it's an interesting new space and we need to think about it. So where is the board up to with all of this? Well, we're currently looking at what is our next step. We need to cost some proposals, and the ones we're looking at currently are to establish a working party of appropriate clinicians and academics to help the board develop an evidence-based approach, to do some social research, to look at the views of the community and the profession. We have talked about putting out a discussion paper, and we'll do that, but we need to get clearer about the questions we're going to ask and about the underlying evidence for the things we might propose, and then get into the space of piloting and evaluating some possible tools. And I know that the GMC has done that in a very big way. So with all the steps they've taken, they've tested them and piloted them and continue to evaluate them. So we want to continue to stimulate the conversation. But I think in this space today, the really interesting issue is what is the interface between the colleges and the regulators, and what is the space for sharing of information. And we haven't really had that conversation to the extent we need to, because when the board started to talk about requiring CPD and how would that work, and talk to the colleges about the fact that clearly it was appropriate that the College of Surgeons would prescribe what surgeons should do, and anaesthetists for anaesthetists and so on. When we raised the question about, so will you tell us if people won't comply or are not complying, the answer was, no, we're not the policemen. We don't want to do that. So that's fine to a level, but it doesn't actually address the problem about non-compliance. So, so the board's going to start to audit. But, is there actually a better way of doing that? Clearly colleges need to be very transparent with their fellows about what's going to happen with information. And the board needs to be very transparent with the profession about, what we're doing. But there is information coming out which may not meet the threshold for mandatory reporting, because there is that framework, but information coming out that may suggest that people at least aren't complying and perhaps aren't performing. And where is the space for a dialogue about that? Can the college actually keep those things in-house and address them? Where is the way in which that should be shared? John's mentioned before that there's a point at which the college is not the regulator, and if the surgeon won't stop operating, something else needs to happen. But I think it would be really good to have some very thoughtful, deep discussion about how those things should work. So I look forward to that. Thank you.